So should I?
Greetings, everyone. My name is Wayne Jennings, and I want to personally welcome you to our forum today. Our speakers will be discussing telemedicine and healthcare, a topic of critical importance to us right now. Our Shaker Heights Unitarian congregation organizes these forums as a congregational service to the community to support personal reflection, social action, and to encourage individual and collective growth for all of us. We appreciate your participation. I'd now like to introduce the coordinator for today's forum, Dr. Jim Boyle, a physician at St. Vincent Charity Medical Center. He will introduce the topic and our speakers. Jim?
Thank you, Wayne. Good morning and welcome to this morning's community forum on telemedicine. We have two very knowledgeable physicians who have extensive experience in this area. Dr. Mark Rood is a family medical specialist with the Cleveland Clinic with offices in Chagrin Falls and South Russell. He teaches an elective on telemedicine to medical students. Dr. David Lopez is the president and CEO of Psychiatry Network, which provides telehealth mental health services for people from Cleveland to North Dakota. So we look forward to hearing from them. Dr. Rood will start the presentation.
Thank you, Jim. Can you hear me okay?
Yes.
So I wanted to go ahead and introduce myself. I am Mark Rood. I'm a Cleveland Clinic physician and helped start Express Care Online, the Cleveland Clinic's telemedicine portal back in 2015. I do have a few disclosures to report. These views are mine. They do not represent the Cleveland Clinic Foundation or its trustees. I've also co-authored multiple peer-reviewed research studies using de-identified data obtained from American Well, which is a telemedicine company, and received no compensation for these activities. My wife is also a registered dietitian and former national quality reviewer for Teladoc, which is another telemedicine company, actually a competitor to American Well. And she receives modest compensation for her services. So first question, who do you think made this statement? It's going to be hard to change heart surgery or neurosurgery very fast, but you can change that primary care stage, and you're going to be able to do more and more things at the primary care level as you disperse the care to where the population is. I am thankful that this was actually Dr. Toby Cosgrove, the former CEO of the Cleveland Clinic, who very early in this last decade gave this interview to Business Insider. And the important thing is that this is what Representative Lewis would have meant by good trouble. To change the world by disrupting healthcare through digital innovation. And that's what we're trying to do as part of the Cleveland Clinic. So as I mentioned, I started telemedicine back in 2015 by launching a program that no one had actually in Northeast Ohio seen before. And it was tough sledding, trying to sell telemedicine when there wasn't a market and where there wasn't a demand, had pushback from all levels. Patients didn't understand what the difference would be in terms of trying to do this online versus going to see the doctor. Doctors were concerned because there wasn't really a model of payment for it. Insurance companies had not yet recognized any advantage to telemedicine, and they were concerned about quality. So the early years were difficult from a number of different perspectives. But that wasn't for lack of trying. On behalf of the Cleveland Clinic, we certainly marketed the heck out of telemedicine. So I apologize for all the full building-sized billboards that you may have seen as you were going downtown. If you were at a baseball game for the Indians, you saw all these ads sweeping across the stadium. If you were watching news programs, Cleveland Clinic was a sponsor. If you were in Terminal C coming out to go back to baggage claim, you saw my picture in the middle of a smartphone, and I had friends who would take selfies of them sitting by or standing by my picture in the phone. So this all changed relatively dramatically when COVID hit. I penned a letter to the editor to Journal of Family Practice about our experience being online at the moment that COVID struck. I termed the article, "You're going to need a bigger boat," taking homage to Roy Scheider, the line from Jaws. We, as the Cleveland Clinic, within 3 weeks expanded our telemedicine visits by necessity from 4,000 per month to 200,000 per month within just 3 weeks. For total 2020, compared to 2019, our virtual visits went up from 29,000 per year to 1 million visits in 2020. We had to train and reorganize our entire Cleveland Clinic workforce of 4,000 providers to be able to do telemedicine, as opposed to my small team of 4 physicians and about 25 nurse practitioners. We developed a telehealth playbook, which we allowed access to people across the globe to copy our model. And we were able, through changes in government requirements, to expand the use of FaceTime, Zoom, Google Duo, and even the telephone under federal health emergency waivers. Telemedicine is defined as the ability to exchange information from one location to another of a medical type using electronic communication. So I would propose that when Alexander Graham Bell called out to Dr. Watson and said, "Dr. Watson, come quick, I need you," I would submit that that was perhaps the first telemedicine visit in the 1870s. Virtual health can drive significant value. The most important thing from my perspective is access, because it eliminates barriers. You do not have to leave your workplace. You do not have to, if you're in rural Texas, drive 4 hours to see a healthcare provider. It's efficient. There's no lower cost of care method than a telemedicine visit. Patients like the convenience, lower cost, multiple channels of care, and flexible scheduling. It allows us to provide continuity care in ways that we cannot do it, and earlier interventions. And it allows us to have patients see our physical presence outside of our bricks and mortar centers, and it can be attractive to certain employers and health plans. Not all telemedicine is created equal. There is what we do most of our work on patients and providers' mobile and desktop, laptop, and tablet devices. But we also, at the Cleveland Clinic, use telemedicine to monitor critical care patients in the ICUs from a central service, so that we can pick up on things that the bedside nurse, frankly, doesn't see or can't be continuously monitoring. We can do inpatient consults using telemedicine, and we have data to show that acute and subspecialty consults at the bedside actually can provide better care than the provider who is sitting actually at the bedside seeing the patient live, and even though we can't reach out and touch them as easily. So in 2015, the Cleveland Clinic expanded its reach, joining a group of physicians from a telemedicine company called American Well. I was fortunate enough to have approached the medical officer from American Well and got access for research purposes to raw data from their nationwide telemedicine service. And I've published multiple peer-reviewed articles on the who, what, when, where, and how of telemedicine visits. One of the things that is helpful in this research is we have 2 outcomes that are measured on every visit. We know the length of time of the visit, and we know whether the patient rated as a satisfactory visit or not. giving it 5 stars down to 1 star. We also can see when patients answer surveys about what they would have done if they had not used a telemedicine visit. And as you can see, most of the most of the patients would have gone to another level of care, be it doctor's office, urgent care, express care, which are actually more expensive than a telemedicine visit, retail health clinic. Certainly emergency room accounted for 5% of patients. Only 12% of patients would have said that they would not have pursued this any further. And then there's a map of pre-COVID where we were seeing patients from. I'm licensed in 16 different states in order to do telemedicine. Not every physician needs to do that, but as the director of Express Care Online for Family Medicine, that was one of my responsibilities. So comparing in-person satisfaction to virtual visit satisfaction, we actually note in the studies that we've done that patients are actually more satisfied with their virtual visit than they are with traditional office visits, comparing 93% to 86%. And so one of the criticisms that we had early on was, well, if you do a telemedicine visit for the physical exam, you have to put exam not performed, but nay. I made the slide full on purpose to show you just the breadth of how a physical examination can be performed. All the things that we can do in terms of assessing whether someone's breathing is labored, whether they have abdominal pain by having them feel their own abdomen, or having them jump up and down a few times to see if they experience discomfort. There are many ways in which visually we can observe a neurological examination or back exam or extremities, or every organ system has something we can do. We're big into quality at the Cleveland Clinic. We actually took over in 2017 American Well's quality monitoring program, and we were able in 2018 to show that we could decrease unnecessary antibiotic prescribing rate down from 67% to 16%. The data that I've analyzed for American Well included 510,268 patient encounters, so it allowed us to do some very robust studies. Our quality involves using evidence-based practices, maintaining telehealth guidelines, allowing physicians access to smart templates so they can be prompted to ask the right questions for the right patient at the right time, collecting all this data and then reporting it back to the providers. One of the advantages of telemedicine is also reaching the underserved community. American Hospital Association reports that 80% of person's health and well-being can be tied to their physical environment, economic stability, education, and food insecurity, whereas only 20% is actually tied to their access and quality of care. So telemedicine is actually really good at being able to do what family medicine used to think of as a home visit, because when we go and do a telemedicine visit with someone's home, we can actually ask them to open up their refrigerator. We can get a sense for their home environment, and we can get a sense for other factors that influence their healthcare beyond just listening to their heart and lungs. Federal government defines nearly 80% of rural America as being medically underserved. That's census tracts in which residents have a shortage of access to personal health services. Eli Saslow did a great article where he talked about one doctor for 11,000 square miles. So in rural Texas, for instance, telemedicine is an important adjunct. But you can be just as underserved living 1 mile from the Cleveland Clinic main campus if you don't have access to primary care services as you would be if you were in rural Texas. Higher, denser populations still lacks access to affordable care. And I would submit that lack of broadband access today is equivalent to allowing someone in rural or urban centers to be underserved. So when we rated or asked our own physicians to put a word cloud together of what was the most important things that we could do to provide better care and keep patients out of the emergency room or hospital, access was the key factor that our providers also agreed. There are challenges. Coverage and reimbursement during the pandemic pretty much universally became full coverage and reimbursement to the physicians. So the pandemic definitely demonstrated value when we didn't know early on whether it was safe to see patients in an office environment. However, as the emergency use authorization for telemedicine will come to an end when the pandemic is declared no longer a pandemic, Congress will actually have to pass some legislation to be able to continue to allow telemedicine to be an option for care. Patients and providers needed to get some comfort with the telemedicine environment, as people have already joked pre-meeting. This is something that is universal across patient and provider experience, but it is improving, I can assure you. Quality has been improving, as I mentioned, and technology. When we tried doing this in 2015 and have 3G or less on cell phones and broadband was slow, video visits were difficult. Now with 4G, it actually is significantly better. 5G might even make that better still. There's also increased opportunity for alternative touches with patients, be they telephone visits, extended MyChart messages, e-consults, where we can actually consult one of our other providers on behalf of a patient and do a provider-to-provider telemedicine communication. We have strong evidence to support that pharmacy visits, behavioral health visits, and other primary care provider visits are excellent ways to get care needs met. Care coordination with other team members, including transitions to the hospital for hospitalists being able to see COVID patients without going in the room, and also what we call shared medical appointments are another opportunity. This allows us all to make healthcare better as we get better outcomes, better patient experiences, better care team well-being, and lower costs of care as we go through digital transformation. What's the future of telehealth? Well, you need to think of telehealth as a tool like it would be a computer or a telephone. We still hold ourselves to the same standard of care as we would in a bricks and mortar office. That's very important, that care not be compromised just because we're using a computer, a telephone, telehealth as a tool. Telehealth is now a household word, accounting for 20 to 25% of all healthcare visits. That is malleable to rise and fall as the needs fluctuate. As we see fewer COVID patients, we have a tendency to see fewer telemedicine visits, but we are finding that the usefulness, quality, and cost effectiveness of these visits still is valuable, and patients, even though they still have preferences, some patients prefer a digital health visit and some people do not. That may be different based on their level of access to computer services, their level of fluency with it. So age may depend upon it, but I have a number of patients who are in their 80s who actually love their telehealth visits. It is therefore important that we use the right tool for the right patient at the right time. As my OBGYN colleagues point out to me, it's tough to deliver a baby virtually. But as you may know, 9/11 has countless examples of babies that 9/11 has helped deliver. Again, we focus on not just primary care, but actually the Neurological Institute at our institution is one of the lead drivers for doing post-op visits from neurosurgery and the like for virtual care. So routine pre-op, post-op, and mental health care is another excellent example of where we can use telemedicine as the right tool. There are some insurances already in Northeast Ohio who are advocating virtual first primary care, where patients are incentivized with zero copay to have their visits tried first in the virtual space and then use bricks and mortar space when necessary, as they are typically more expensive visits. Reimbursement needs to be addressed so that we have continued parity after the pandemic ends. And that, as I mentioned, requires legislation to update the post-COVID rules. And I would submit that broadband is a public health necessity for access. HIPAA was waived for compliance during emergencies. That's how people could get FaceTime visits in Google Duo. Those will likely have to change back to HIPAA compliant visits. So bye-bye FaceTime and Google Duo unless they become HIPAA compliant. And licensure, my need to have had to obtain 16 licenses across 16 states. Although that was waived during the emergency, it's certainly one of the most expensive problems on the side of the provider. So I see regional licensure compacts becoming more common as we move forward. And my favorite is that telemedicine is one of the few places as a physician where you don't have to wear pants, and neither does the patient. So with that end, I will stop sharing my screen and turn it back to our moderator.
Okay, and thank you, Dr. Rood, and Dr. Lopez will start now.
All right, thanks, Jim. And Dr. Rood, thank you. That was very compelling data. Thanks for having me this morning, everyone. And I have great respect for the Cleveland Clinic, and as I mentioned, the data is just awesome that Dr. Rood presented. I come from a little bit of a different position. My story is more as one of an individual practitioner, struggling to provide top-notch services to my patients. That where I came from was up in North Dakota, and I was in the military, and a lot of my guys were coming back. I was chief of clinical services in the Air National Guard for my fighter wing. And a lot of the guys were coming back from being deployed overseas. And then I had this individual practice where people were coming to see me from disparate areas. As you can imagine, up there, the distances are pretty vast, but people live up there and they need the services. And so that was really where I got started back in the, like maybe 2007, 2008, thinking about doing a telemedicine initiative. I sort of was one of the pioneers in my space, my specialty psychiatry. And really, my story goes back even farther. I have to say, my dad is a retired surgeon in Northeast Ohio, and he was one of the first people to start implementing laparoscopic surgeries instead of doing laparotomies. He went and got training initially when the first laparoscopic machines came out, and so we always had like a technological bent. And then when I was doing residency in the late 90s, I remember I was on a neurological rotation, so my neurologist was supervising me, and we were supposed to provide care for these people at a prison that was remotely located off-site from the hospital where I was doing the rotation. And my neurologist, it was very busy schedule. Every other night I was on call, and I was like, man, I have to go out and drive like 40 miles in the middle of winter up in Minnesota. It wasn't like a thrilling prospect. And my neurologist told me, hey, Dave, if you want, I have this old computer equipment that was supposed to be used for some type of, connection with the prison. And if you can get it set up, because it's in a closet and no one's really activated it, guess what? You won't have to drive out to the prison. So I started putting things together with this old equipment. And believe it or not, I was able to get a connection with the prison. And that was the first time I ever did any type of telemedicine connection, was with prisoners in a remote location from the hospital up in Minnesota. And it worked wonderfully. And it was very well received by the prison administration, as you can imagine, because of the safety of not having to go in, because it was a high security prison. And and my neurologist loved it. I got a very good evaluation on that rotation. And then that always stuck with me. And then for the next 10 years, I was just a traditional psychiatrist providing face-to-face services. And then in the military, when everyone started coming back, we started to think, myself and the wing commander, this might be a good initiative to try and get going to provide services to our remotely located members, a lot of whom couldn't come in on the weekends. And so I actually went and gave presentations, believe it or not, to high-level generals at the Pentagon 2 or 3 times, and we were able to get an initiative going. But of course, there's always politics in those type of situations, and so we were able to get some utility out of that. But it didn't go too far at the time. And then what happened for me after that was I met a guy in Washington, D.C., who was a businessman. He came from the IT sector, worked high level at PeopleSoft, EDS, Oracle, and he was interested in trying to provide these services in the civilian sector. And so he had some connections. And again, myself being an individual practitioner, I was always more focused on delivering the services rather than the back end, the business side, the administrative side. And so my colleague, Chris, who's still with us today, was able to facilitate some pilot projects with some large hospital organizations. And as Dr. Rood had mentioned, one of the big barriers to entry in this space initially was that coming up with workable revenue models. And at that time, back in probably 2010, 11, 12, the insurance companies were looking askance at anything that was deviating from the traditional face-to-face. And so what Chris was able to do is figure out some ways to deliver these services through a combination of grants and fixed pay for service type of models that allowed us to start actually providing virtual outpatient clinics up in the Dakotas and Minnesota. And so we started doing that, and pretty soon we started getting calls like within a few months after doing these services from the emergency rooms and from the inpatient units, because these are rural hospitals. It's a much different paradigm than in the urban setting. Most of these hospitals, are 20 to 30 bed entities, if that. But, again, people live up there. They utilize the ERs. They get admitted to the units, and they had a glaring lack of specialty care in the area of mental health. And that's one thing I need to add too. Mental health is such a particularly well-suited discipline in medicine to provide these services. And as Dr. Rood noted, you can't necessarily deliver a baby too efficiently, online. But mental health services, with the need to, hear what the patient's saying and observe, this is very well suited. So we were able to get this going. And then, as I mentioned, the emergency room docs and the internal med docs on the hospital units, once they learned of what we were doing, they were, hey, we have a patient in the emergency room. He might be psychotic or suicidal, or he's definitely intoxicated. Can you come online and talk to him, because we can't find a bed anywhere, in the 300-mile radius of where this particular community might be located. So all of a sudden we had this new job that developed, job opportunity, I guess, or responsibility. And we started providing the emergency room consultation services and doing inpatient consults for people who might come in with an MI or a pulmonary embolism. But the doc was like, this patient's very anxious or very depressed. Can you evaluate them too? And at the end of the day, it added up for a better quality of care. And so we started growing slowly along these type of lines. And then a few years ago, maybe about 5 years ago, again, more personally related, my parents started having some physical health issues down here in Northeast Ohio. And for purposes of being close to my family, I started spending a lot of time down here to make sure everything was going all right with them. And we ended up relocating our main offices down to Northeast Ohio. So we have our main office here, but we still are providing services up in North Dakota and Minnesota, as I mentioned. And since that time, we've grown. We started establishing a presence here in Cleveland area in the state of Ohio, as well as Illinois and Washington State, and we're moving into other states too. And we started growing. So even though I'm an individual practitioner, my colleague Chris, I mean, recognized that we need to keep trying to grow, and so we started bringing on some other practitioners and forming a provider network. And of course, with the pandemic, things have really started to there's just been an increased demand. And even in the best of times, I'm sure many people can appreciate that there is a need for mental health services. You know, many people, unfortunately, lives of quiet desperation, struggling with mental health afflictions such as depression and anxiety. And, you know, there's a stigma associated with that. And I think one of the things that telemedicine and virtual mental health services have afforded people is that that sense of discreetness or anonymity, so they can get online and get help. And you know, where we first started in kind of the rural arena, providing services to populations that you know, didn't have access to specialty services. You know, Dr. Rood made the comment that you could be a mile away from the Cleveland Clinic and still be suffering from quality care. And that is one of the things that we've come to appreciate as an organization over the last couple of years since we've established ourselves in Northeast Ohio, that there are a lot of people in this community, or I should say urban communities in general, urban, suburban, not just rural. You know, I came from the rural environment. And you know, what we're seeing is this resonates with people across the spectrum, whether you're suburban, urban, or rural. People are coming to embrace this model of care for the, you know, some of the reasons I mentioned: the access, the lack of stigma, the anonymity, and the payers are coming around too. And that's been something that's been interesting to see, because it certainly for the first number of years that we were in existence, we were definitely, I would say, pioneers trying to, you know, how would you say, carve out and be trailblazers in this new space, which is essentially you're delivering clinical medical level services, but in a new healthcare delivery channel is the way I like to explain it. You know, you cannot just hang a shingle out in cyberspace and start delivering these services. It is still medical level, and things have to be regulated in terms of the delivery and care, just as if you were doing it in a traditional brick and mortar site and person to person. And you know, dare say that you know, that's been one of the big challenges, is making sure that we, you know, live up to those standards. Because you know, you start to work in a new healthcare delivery channel, then you find new challenges that come up, things that you couldn't even make up start to materialize, and you're like, oh wow, we didn't really think about accounting for this in terms of like complying with like the prevailing standards of care. So I guess I would say that you know, while I'm a huge proponent of the delivery of services in the telepsych space, I think the benchmark to me will always be face to face in terms of delivering care. So what I mean by that is that no matter what we do, if I'm seeing someone in Seattle, Tacoma area, and I'm here in Northeast Ohio or in Minnesota or North Dakota, wherever I'm delivering the service from, or one of my providers, we're always striving to replicate the level of care that would be delivered as if I was sitting in that clinic in Tacoma, Washington, for example, face to face with that patient. So it's not just a fly by night. And, you know, again, like with FaceTime and Google Duo, you know, I'm very you know, you know, I want to be HIPAA compliant in everything that we do. So we're going to make sure that the telemedicine platforms, because there's many, they've always almost become commodities over the past year, you know, and we can plug and play. I mean, we're technology agnostic. After all, we're providers and we're the ones providing the services, but they have to maintain, the minimal HIPAA compliance standards and the licensure. Again, we want our providers licensed in the states that they're delivering the services, even though this is a time of emergency. We're still striving to make sure that we comply with what the standards are, and we want to be part of the dialogue in helping as providers what those standards will be going forward in delivery of telemedicine. But I guess I would circle back too is that there's many disciplines in medicine. I just want to emphasize where my area of expertise is on the mental health side, and again, I feel that this is a discipline in medicine that can be essentially like a tip of the spear in terms of helping the evolution of telemedicine in general, again, because mental health services are so easily delivered in this type of space. So that's a little bit about my background and where we are. Individual practitioner, itinerant psychiatrist up on the prairies of North Dakota, trying to deliver quality of care. And this represented an opportunity for me to try and be not necessarily revolutionary, but evolutionary in terms of getting the services out to people who need these services. So I really appreciate Dr. Boyle giving me the opportunity to share my story. And with that, I'll hand it back to you, Jim, and see if the congregation has any questions for myself and Dr. Rood.
Thank you, David. So again, there's a Q&A button at the bottom of your screen, and type in your questions for the physicians, and Laura and Cliff will relay the questions to the speakers. So we'll start now with the question and answer period.
Thank you. This is a great presentation, a lot of information. I'll start with an anonymous question. Dr. Rood, and I'd address Dr. Lopez also. What about the emotional relationship and the amount of trust that exists between a patient and a physician? The simplicity of shaking a hand or holding a hand at bedside. Physical presence can be healing, but it can't be measured. What's your response to that?
Thank you for the question. I would submit that fortunately we having the presence not just of a telephone communication where you're hearing the audio of a person, but you're actually intimately in their home because you actually see them and they see you in your office on the video camera. And especially if it's a patient that I have a previous relationship with as the primary care physician, we maintain that degree of intimacy as we talk about subjects that are intimate. Examining someone is an intimate touch, even if I can't actually touch their skin. I'm examining body parts. I am asking them to do things in their own home and talking about very sensitive medical issues. My common patient has multiple morbid conditions, multiple disease conditions. They have high blood pressure, they have diabetes, they have heart disease, they may have depression or anxiety or cancer, and often have multiple of those at the same time. So we see this as an extension of our care that patients already know us for. If it's a new patient, it's still an intimate environment. Now, as people realize having a year plus of having to do Zoom funerals and Zoom meetings with their bridge group, or being able to see a grandchild remotely, yes, it loses something in the translation. We're very cognizant of that. And that's why the Cleveland Clinic tried opening back up its offices as soon as we knew that we could do it safely and not be a vector to transmit the coronavirus to our patients. We took great care to be able to make sure that it was safe to come back to our office. And this will not be right for everyone, but because we have such an access problem for my work in primary care and Dr. And our psychiatrists work in psychiatric care, this is an important extension of our reach and has merit and value from my perspective.
Dr. Lopez, do you have a response at all?
Sure, I'd make the observation, in my experience working with people on a virtual basis, you're right. I mean, I think one of the, obvious challenges is the connection. And again, I go back to the statement, you just can't hang a shingle in cyberspace and start providing the services. I think as a provider, one of the challenges, is having that therapeutic or empathetic connection. And so, when I'm talking with my providers and training them or residents that, I've taught, I really emphasize it's another level that you have to step up, whether it's as simple as getting the camera angle, because sometimes, people hang the camera angle and they'll be looking like this and the patient is like, what are you doing? You're not even paying attention to me. And, you'll get that complaint even when they're in the room with you, so I think that therapeutic connection is very important. But I will say when you go into these rural communities and you go in as a caring provider willing to listen and to observe and to help, people are very grateful. I can't tell you how many virtual handshakes that I've done, over the last few years. And that's not me initiating that. Patients, coined that term with me and said, hey, I'm sorry that we aren't together. Can I give you a virtual handshake? And I'm sure, a virtual fist pump, So we do those like all the time, and I think one of the things that I've seen is, whether I'm working with a rural community in Illinois or in North Dakota, I really, I personally, I guess I can't speak for every provider, but I come to feel like I'm almost like a part of that community and the fabric. And I'll make periodic site visits to the different communities. So on-site visits, to see what's going on, talk with administration and things like that. But, you become like, you become a part of that and people start to appreciate you. So I don't think that the barriers there are as, and then actually, again, going back to the anonymity, I think people sometimes like the distance of being separated on a computer. Sometimes people get paranoid. There's an element of technology paranoia that can be in play with certain individuals. But I think the large population, they appreciate it. And so it's not as that has not been as big an issue as I originally anticipated.
Yeah, I get it. Yeah, I lived in rural Wisconsin for a long time, so I get the distance and the weather and all that stuff. But here's another question. This is a really simple definition question. What does HIPAA mean? You mentioned HIPAA compliance, and how is that different on telemedicine? And I'm thinking particularly, you're in a household and you're meeting with a doctor. My husband downstairs can hear my conversation right now, and so how do you get that privacy issues? Or you hear about people being Zoom bombed. Does that mean that people can Zoom in on your Zoom meeting and listen into what's going on? So let's throw that out there.
So I'll start with that. I would just clarify that HIPAA is the Health Insurance
Privacy
and Privacy Act or something like that.
Health information.
Privacy Protection Act.
Yeah.
Right. But so what it is, it's a law that says that physicians have an ultimate responsibility to protect private information. So identity, birth dates, social security numbers, all that information. Physicians have a responsibility to make sure that patients' privacy is protected, especially in the sensitive area of healthcare, because patients are very keen to make sure that their mental health issues are not shared with their employer or with the public at large. And so in order to have a bricks and mortar visit with your doctor, you sign something that acknowledges that these are the rules, and we sign something on our end. And if there's a violation of that, that can be a fee charged back to the offending physician of $10,000 per incident. So it's a huge financial penalty to physicians if they violate this law, because the government considers privacy to be a very important nature of or feature of a doctor-patient relationship. Having said that, therefore, when you're going into the virtual space, it's critically important that you're using a platform that has the ability to have encrypted data, as opposed to FaceTime or Google Duo, in which those features are not present as part of the platform. So at the Cleveland Clinic, we do MyChart Zoom calls, and you might say, well, gee, if it's Zoom, Zoom's not an encrypted platform, but we pay a premium to get a version of Zoom that actually does encrypt the data to protect patients' safety, privacy, and comply with HIPAA. However, temporarily during this pandemic, since physicians who were not part of large health systems had trouble engaging with their patients and needed care, had to be done through any means necessary, the federal government gave a temporary waiver of the HIPAA requirements to allow needed care to happen. So that's why your physician, if they were not able to connect on the encrypted platform, could flip over to FaceTime or Google Duo and have the call anyway, because it was the right thing to do during the pandemic. That's going to disappear as the pandemic rules disappear, as we're able to get people vaccinated and healthier. And the federal government, once it removes that, all telemedicine visits will have to go back to proving that they're doing so on an encrypted platform, which is HIPAA compliant.
Dr. Lopez, any comments?
Well, I believe in the concept of HIPAA, and as I mentioned earlier, I just the standards that we try to maintain are top notch, and second to none. We do not want to compromise the quality of care that we deliver, even though we may be delivering it in a virtual environment. I just really believe in the importance of maintaining the integrity of the doctor-provider-patient relationship, and that includes having the confidentiality that's needed to provide very good services and help heal patients in need.
Chris, you have another question?
Yes, this one is for Dr. Lopez, and it's a quick question. What is laparoscopic surgery?
Okay, so in the old days, and my dad's the surgeon, but I'm going to give you my understanding of a laparotomy was where, say, someone had an appendix or an acute gallbladder, and they'd have to have the gallbladder or the appendix removed. In the old days, they'd take you, put you in the OR, the operating room, and they'd give you a big bad incision right down the middle of your abdomen to open it up and go in there and extract the gallbladder or remove the appendix. In the current times now, if the situation's right, for the vast majority of patients, what you can do is use like robotic instruments, and you make little incisions rather than a huge incision down the middle of your abdomen or wherever they would do it in the past. You can just make a couple of incisions and do what they call a laparoscopic procedure, where you insert the sterilized instruments into the interior of the abdomen, and then again you do it remotely. You're watching a TV or a video monitor, and you're seeing the interior of the patient's abdomen, and it's a much less stress on people in terms of chances of infection, getting what's called a peritonitis, or complications in terms of there's a whole host of complications. Like if someone is older, medically compromised with, obesity, diabetes, heart disease, you just put much less stress on the system by doing the procedures with as minimal invasiveness as possible. So laparoscopic is more the modern way of performing surgical procedures. But back in, 50 years ago, everyone was getting the major incisions to remove or to do surgical procedures.
Thanks, Dr. Lopez. So here's a question back to, telemedicine. In your opinion, what is the impact telemedicine has on the insurance companies? Are insurance companies supportive of this? Do they charge differently for these visits? In the long run, is it something they may see as being able to stack up charges in a shorter period of time? And then what is the effect of you as a provider with these telemedicine visits? Because you still have all your back end work of coding and billing and charting your experience.
So I'll take a stab at that. So prior to COVID, 26 states had laws that required parity, meaning that if a insurance company covered a bricks and mortar visit, that they also had to cover a telemedicine visit. Didn't necessarily require that they pay the same amount, but it had to be at least covered. When COVID hit, that took Ohio, which was not a parity state, and flipped it into a parity state as it became federal rules that insurance companies had to cover telemedicine visits as well. Typically, there are lower costs for most providers who are providing a telemedicine visit, but the costs are not zero. You still need staff to help patients when they can't connect. You still need certain requirements met for assessing issues about social determinants of health with the visits and other requirements that primary care has to meet standards of care. So, but all in all, I think both providers and insurance companies agree that telemedicine is a lower cost way of providing care. We have some data on that in the research studies that I've done, showing a study through Anthem Insurance in which they found that virtual visits were definitely the lowest cost care, even compared to an urgent care, a retail health clinic like a Minute Clinic, and certainly $1,600 cheaper than going to the emergency room on average. So when you're dealing with evaluating should telemedicine be continued for reimbursement by an insurance company, it's a heck of a lot cheaper than going to an emergency room, and absolutely cheaper than if the patient is inadvertently admitted to the hospital, especially for something that could have potentially been managed in that environment.
But part of the question is that your time as a clinician is the same whether you saw the person face to face.
It typically is, in that we do a history, we do a physical examination, we review notes in the chart, and we have to document using standards appropriate for the visit. So when you're done doing all that, a 20-minute visit in my office is about a 20-minute visit in the Express Care Online space as well.
Mm-hmm. But then if they pay, but then you don't have the nursing staff or the building costs. So is that why there's a lesser reimbursement in some cases?
Right. Well, your tools of the trade, you haven't had to use cotton swabs. You haven't had to have anything other than computer, although you still need a space for that and you still have to maintain that equipment. And those fees have to be built into cost somehow. So our cost overall in the system is pretty close to that of a bricks and mortar visit, but is still slightly less.
Thank you. Dr. Lopez, any thoughts on that?
Well, I guess my thoughts on this, Debbie, with some of the, challenges that I felt that we faced earlier as a small, provider organization, the insurance companies were not receptive at all to this model of care. I mean, some were, as Dr. Rood mentioned, there were parity states, and states were coming along, and then of course the pandemic accelerated, the whole adoption of telemedicine, in a number of disciplines. And again, going back to my area of expertise in mental health, I guess, it depends on how you look at it, because, you have two levels. You have the delivery of care, I suppose, into what I would call like a traditional, brick and mortar space. So, my provider may be like in Florida, but the hospital site may be in rural Minnesota, but it's still a provider to a brick and mortar facility that a patient is coming into, even though the provider service is remote. Then you have this other level where you have provider, you almost could call it a consumer level, where someone might be at their apartment or at their office, and then you're providing that level of care. And of course, there's risk associated with that, because you don't have the back end support staff at the remote site as if they were going into an outpatient clinic at a hospital. And so I think the insurances are going to be worried about, and understandably so, about liability in those type of situations.
Or fraud, because maybe you're
Absolutely
faking
fraud.
the visit.
That's correct. But on the other hand, if you take a cynical approach too, you're going to see that you're going to ask the question, well, would the insurance companies want to keep this model going, or do they want to go back to the way it used to be? Because, with telemedicine, the prospect of higher utilization also presents itself, because people are going to say, oh, this is easier for me to access this care.
Right.
And so I'm going to get this care. And normally I wouldn't use my insurance for anything, because it's like 4 months to get in to see a provider, but if I can just get online in 3 days or on demand or a week or whatever, I'm going to use it. And the insurance companies might not like that either. So there's this kind of tension there, I think, so definitely we have to see how it evolves. And I'm just not an expert on that side of things, except insofar as that it was like pulling teeth to get reimbursement a few years ago.
Right.
So and it still is always an ongoing struggle to to work with the insurance companies from a individual provider perspective.
Chris, did you have a question there?
Yes, Mary asked a question. She wants to know if there are technological fixes to allow language translation during telehealth visits.
So I'll take this. The Cleveland Clinic is blessed with integration into their network with translators who we can get engaged in a visit as a guest live in our virtual visits. So we have a robust service that allows us to invite in guests to our visits, and that's how we are able to maintain communication with patients in whom English is not their preferred language.
So you have face-to-face translation in a sense.
Exactly.
As opposed to one of those translation computers approaches.
Right. Yeah, this is not artificial intelligence. This is human intelligence.
So then, Dr. Rood, perhaps in theory, you could have a meeting with the patient and yourself, and also perhaps a doctor in China that doesn't speak English.
I don't know enough about the laws to know whether patients sighted in foreign countries can do telemedicine visits in the United States. I honestly don't know the answer to that.
I was just asking technically, not legally.
Right. Yeah, technically you're probably correct. I have seen patients in Abu Dhabi who signed onto the platform and somehow got through, but they were actually a resident from Cleveland, and they were in Abu Dhabi, and they signed onto their platform, and I did a telemedicine visit, and only halfway through the visit did I understand that they were actually in Abu Dhabi at the time.
That's great. This is a question from an anonymous attendee. In general, based on your experience, are African American or Hispanic people are as supportive of telemedicine as other mainstream groups? And I'd also ask, again, coming from rural America, are rural Americans supportive of it? What is the general receptivity of your patients?
So I'll take a stab at that. So I think the question was about receptivity. And I think the communities that you mentioned are all, or not all, but mostly receptive, as I think consistent with the general population. I think in the patients who have needs of income and access to technology, as much as we would see this as an excellent tool to expand access, if patients don't have access to technology, if they don't have access to broadband, that can be a significant detriment, which is why I link broadband access to a public necessity. Having said that, a surprising number of patients, even in lower socioeconomic classes, have access to a smartphone, and our system works excellent on a smartphone. So if they can have smartphone access, now obviously that doesn't mean that they get paid, that their phone bill gets paid in their health encounter, but if they have access to a smartphone, we can do an excellent telemedicine visit. And from the rural perspective, sometimes broadband coverage is spotty there as well. But also cell towers can be few.
Oh, in mountainous areas, cell service is notoriously terrible, right? Yeah. With the interstate medical care mentioned by Dr. Lopez, what will happen with licensure post-pandemic? Will telemedicine lead to regional or federal medical licensure? I know I'm a nurse, so in nursing, we have multi-state compacts, so it's easy to get a license in another state. And I don't know if medicine has done that same thing, physician medicine.
So I'll tell you what I know. Multi-state compacts do exist in medicine. However, the state of Ohio has a very conservative view about allowing themselves to participate in a multi-state compact, so they choose not to. And the reason is that they don't want the quality of care to be relegated to the lowest common denominator. So they're afraid if Arkansas, for instance, or Mississippi, a state that has relatively lax rules on quality of care and governance of supervising their physicians. Ohio, having a very strong state medical board and state pharmacy board rules and regulations, wants to make sure that its value and power to regulate its providers is not limited to the state with the lowest common denominator. So even though I am licensed in states that are parts of compacts, compact rules state that you have to be governed by the state in which you actually reside in and provide most of your services. So I'm not allowed to use the fact that I'm licensed in states with compacts to use the compact itself. I have to have an individual license in every state that I'm in. Having said that, I do believe that some of those rules can improve over time, but it would require the federal government actually making an overall rule that then gets determined that it supersedes state law.
Oh, that would be such an overreach of the federal government, don't you think, to go into a practice guild and say, hey, your practice guild isn't any good? That's.
Well, I think, again, it could be done very narrowly, but it would require something like that in order to bridge some of the, or mediate some of the fights that are going on between states.
I mean, to be clear, it's the physicians who determine the rules. If you're a group of board of medicine, it's not government that made these rules, right?
Well, the only pushback I'd have on that is that physicians have had a hard time getting membership onto the state medical board in the last decade.
Okay.
Part of that is because the priorities have been elsewhere, working on treating the drug problem, in which physicians were felt to be part of the problem. So the state medical board didn't want necessarily physicians on the state medical board. And there were other priorities having to do with some social issues that some of our some parties felt were important to push, and so they ended up stacking the board with people who believed a certain social and religious philosophy.
Gotcha.
I'll leave it at that.
It's politics, yeah. Chris?
Yes, can telemedicine provide care for someone in hospice care or who is confined to bed at home?
So obviously, from my perspective, that's one of the values of telemedicine, that yes, it can be done. Whether it's the best care for that particular patient is an individual decision based on the patient's needs and the provider. And so I push back against a one-size-fits-all strategy, but the answer is yes. If technology can get to where the provider, where the patient is and the provider, those visits can be done.
And one for Dr. Lopez, can telemedicine help with suicide prevention?
You know, I would argue absolutely yes. I mean, you know, the challenge obviously with suicide prevention is, you know, you really never know if I mean, I'm not saying this I'm saying this in all seriousness. You really never know if someone's going to commit suicide until they, you know, commit suicide, you know. So I think the thing is that if people are in desperate need and they're feeling, you know, emotionally distressed and hopeless and despondent, and, you know, having these type of services available, absolutely 100%. I can't measure how many suicides we've prevented, but it's my clinical instinct as a provider that we probably, you know, saved and, you know, mitigated a lot of, you know, tense situations across the upper Midwest over the last number of years. Absolutely.
This is a question about buildings, actually. So if telemedicine really takes off, there are losses to the facility through, though not to the doctor themselves, but loss in parking fees, utilization of consumables, loss of other staff, usage time, etc. What do you think about that? Do you think it'll hurt the hospital campus?
You know, I can't, again, I'm not like affiliated with a large hospital organization in general, but I can say I don't necessarily know that that will be the case, because we provide these services, as I mentioned a few minutes ago. I mean, there's two levels of virtual. You know, you have the, how would you say, almost like the consumer approach, where you're a provider going to a person's apartment or to a person's office, but then you have this whole other level of organizational delivery that we set up, that we're set up for now, and that we do like every single day, where we provide the services to a number of different facilities. So there's always patients going in. I think if anything that's driving down utilization is the fear of, you know, contracting, you know, the virus by going to a fixed hospital location. I talk to patients and they're like, man, I'm not going to go. You know, I'd rather do this all day long than go to a hospital at this point, because they're, you know, super afraid of catching the virus, you know, and getting ill. So I think that more than anything, I think there's enough need for medical services that there's always going to be a role for the hospital site. And I think that these services will be just embedded. Again, it's just another healthcare delivery channel or way of delivering medical services. It doesn't change the fact that people will still use these sites. I think, you know, there'll be more of a consumer trend or approach as time goes on, but I still think there'll be a role for the hospitals as well.
Hey, Chris, did you want to ask that last question about American telemedicine companies that you have?
Okay, let me find it here.
I have it right here if you want me to read it.
Oh, you go ahead. Yeah,
Okay.
I have to pull up my email.
So I am given to understand that American telehealth companies have launched tools to help users self-triage with COVID and other health problems, particularly on various screening tool websites. These efforts seem meager compared to those of Chinese telehealth firm WeDoctor. Within a 12-day period of time, WeDoctor received 90 million site visits compared to 1 million free virtual exams. Why is China apparently so far ahead of the United States? And does this matter?
I'm a little bit familiar with WeDoctor and what China has done. I would submit that it's hard to know the accuracy of data when it's sort of crowdsourced across such a broad platform. I think that a lot of rules that are set up to guard patient safety would have to be significantly changed in the United States in order to allow that level of care. So I, as a practicing physician with 35 years experience, have a little bit of chills regarding just ensuring that we can have consistent quality, efficacy, and meet standards of care that are established in the United States.
Dr. Lopez, do you have a response?
I mean, I'm certainly no data expert. That's not what I do day in, day out. But the first question I would have is like, what's the validity of this data that they're, running, by you? That would be just my first question. Is the data valid? And because you can't really have a dialogue unless you know about the validity of the assertion.
Right. I might say it's centralized healthcare too, which we do not. We have a very piecemeal organization in this country. I think that was our last question. Any last comments either one of you would like to make about telemedicine and the future of it for yourself or for the country as a whole?
Well, I'll mention that I'm excited to have had the opportunity to talk about something that has been near and dear to my heart over the past 6 years now. I have been asked to lead a new initiative, imagining how we could further expand access to underserved populations. And underserved could be areas just outside the Cleveland Clinic's reach. Think areas like Sandusky or Mansfield or Youngstown, where we don't have much of a presence. And patients are asking us, can we have a virtual primary care relationship with a doctor where we would come in if we absolutely have to, but would like most of our visits to be through a virtual space. These are millennials, these are late Gen Xers, even baby boomers who may have diabetes, but that's their only problem, or high blood pressure. And technology exists to have remote monitoring devices and other things that can enhance the telemedicine experience. So I've been given this challenge since January 1 to develop a means by which we can actually create a new model of healthcare delivery called virtual primary care. And that's going to be rolling out as of July 1st. It's something that I wanted to be the gray-haired doctor in the room to, if we're going to do this, to do it right, and to make sure that we're holding up to the same quality standard as we would ask of our bricks and mortar offices. But I think if you think about looking to find the shopping mall in Northeast Ohio, compared to where we were 10 years ago, shopping malls are few and far between. They've essentially been replaced by Amazon stores or delivery centers. So imagine if 5 years from now, 30% of the bricks and mortar facilities owned by the Cleveland Clinic are obsolete, mothballed, and don't need to be used for patient care. I can envision a time if telemedicine goes to its next logical conclusion, especially with the entry of players like Amazon into the healthcare space as they're planning to roll out. This could be a new paradigm shift in healthcare delivery where we're giving the right patient the right care at the right time.
I'd like to thank Dr. Rood and Dr. Lopez for a wonderful presentation this morning. We learned a lot. I know I certainly did. And I would like to remind you that our next forum is on April 11th, Earth Day Stories from Ohio's Gasland with Dr. Debbie Lauder and Tad Auk. And thank you for coming today, and thank you again to our speakers. Thank you.
Thank you.
Thank you.